So our next talk is going to be on the story behind the use of the internal brace in the ankle. And it gives a history of a lot of the research that I've done over that period of time using the internal brace. You certainly can figure out that if you're giving talks entitled The Story Behind or Evolution of Something, that you're really old and it's really time to stop giving talks. But I hope you I hope this to give some of you insight about how Gordon and I met related to the development of the internal brace and then the evolution of augmented ankle repairs. These are my disclosures, and the relevant ones are my research support from Arthrex and my consulting arrangement from Arthrex, some of which involve studies on the internal brace. But I receive no payments for speaking at this meeting, nor do I receive royalties for any products related to this talk. There's been a significant change in how ligament injuries and instability of the knee, shoulder, and ankle have been managed over the past century. Bracing has given way to surgical stabilization, and tenodesis procedures have lost favor to anatomical repairs and augmentation. The goal has always been to have a better repair that restores the injured area as close to normal as possible to allow more aggressive rehabilitation and weight-bearing and earlier return to daily activities, recreation, and competition. In the pre-anatomic era, tenodesis procedures were used most commonly for severe lateral ankle instability, with gradual transitions from non-anatomic reconstructions to more anatomic ones. In my residency and fellowship, I was primarily exposed to the non-anatomic version of the Christman-Snook procedure. It wasn't until Leonard Brostrom published his article in Acta Chirurgica Scandinavica in 1966 that anatomic repairs for lateral ankle instability became popular. And the first augmentation was added to a repair of the lateral ankle ligaments by using the inferior extensor retinaculum as described by Nathaniel Gould. It really didn't become a standard in the United States until Bill Hamilton published a popular monograph leading to use of the Brostrom-Gould procedure as a preference in many teaching programs. Dr. Hamilton felt that this procedure was adequate for almost all lateral ankle instabilities, including those with a subtalar component, but importantly, it required good local ligamentous tissue, identification and advancement of the inferior extensor retinaculum, immobilization, and careful guided rehabilitation. As I mentioned, there's been a significant change in how ligamentous injuries and instability of the knee, shoulder, and ankle have been managed over the past 38 or so years. A more aggressive ACL rehab program was introduced initially by Dr. Steadman around 1985 and required a stronger repair. Tenodesis procedures lost favor to anatomical repairs and reconstructions. After early success with the Brostrom-Gould procedure, the question arose as to whether it was good enough for all conditions. There were several who felt that the Brostrom-Gould wasn't satisfactory for all cases of lateral ankle instability and converted to other procedures such as a more anatomic Christman-Snook, which Mark Colville published in AJSM in 1995, or an anatomic autograft using a gracilis tendon graft, as had already been used for some time for the ACL and published for the ankle by Mike Coughlin in Foot and Ankle International in 2004. Or Bob Anderson's Brostrom-Gould augmented by 1/3 of the peroneus brevis. This was mostly level 5 evidence, though there were some level 4 reports starting to show up in the literature. While in Houston, we did several studies on this method showing that it had adequate strength of fixation when there was good tissue, but still needed a period of immobilization. In 2008, out of Lou Schoen's lab in Baltimore, this biomechanical study was published showing that instability from elongation of the ligament repair could occur after unprotected mobilization following a Brostrom procedure. This study by Nick Mafuli in London, published in AJSM in 2013, provided some background clinically for the concerns regarding Brostrom repairs for all individuals after they found that only 58% of their patients returned to their pre-injury level of activity, 16% returned to a lower level, and 26% abandoned athletic activity. Just prior to this, I moved from Houston to Vail, and Rob LaPrade joined us in 2010. I began copying his pyramid approach to research. Our fellow at the time was Norm Waldrop, who is now one of the team doctors for the University of Alabama. While with us in Vail, he did the research and published this initial paper to evaluate the strength of Brostrom repairs. And he found that the load to failure at time zero for a Brostrom, whether with suture repair or with suture anchors, was still less than half the strength of the native ATFL. And stiffness was also about half the stiffness of the intact ATFL. This led to our conclusion that regardless of the repair method, the Brostrom repair had to be protected to avoid premature failure. We then went back to our basics and published this anatomical study in the Journal of Bone and Joint Surgery in 2014 to determine precise origins and insertion of the lateral ankle ligaments, which you can see here. This gave us exact locations of the origin and insertion of both the ATFL and CFL related to bony landmarks. Tommy Haitmanic, one of our fellows, then added the radiographic identification of the lateral ligament structures to confirm accurate placement of bone tunnel origins and insertions for the lateral ligaments. This was published in the American Journal of Sports Medicine in 2015. This is a slide that was given to me by Bob Anderson, who began using the Brostrom-Gould procedure, but then he also augmented it with a small tendon weave using 1/3 of the peroneus brevis tendon, as with the Evans procedure. And this has worked very effectively for him. But there are some specific contraindications that he has identified, such as not using it for ballerinas or gymnasts due to its restriction of ankle inversion. Following a visit by Gordon Mackay from Glasgow, Scotland in 2012, we were introduced to his concept of using suture tape as an augmentation to tendon repairs, and we began doing research to validate this. The first study was a biomechanical study done by our fellow Nick Viennes, published in the American Journal of Sports Medicine in 2014. The suture tape was placed over the traditional Brostrom-Gould repair and secured with a very slight bit of laxity, 1 to 2 millimeters, to avoid stress shielding the repair and thereby acting more like a seatbelt. This study showed us that the ultimate load to failure of the surgically repaired ATFL is only about 50% that of the native ligament, while the internal brace had a strength to failure of 250 newtons plus or minus 122. After this study, this became my standard procedure for most lateral ankle ligament instability cases, a Brostrom-Gould with suture tape augmentation, or with the internal brace augmentation. So there were still a few circumstances where I would favor a tendon graft, like a large athlete or an obese patient, a failed lateral repair or reconstruction, a severe degree of instability, hypermobility, or a neuromuscular disease, or tarsal coalition, among other things. It's always important to be prepared for all circumstances that we encounter in lateral ankle ligament surgery. And here are just a few that I always hope that I have recognized before the operation rather than afterward. The top of our research pyramid is always patient outcomes, and we are still in the process of doing this with our patients. We just published in the August 2023 publication of Foot and Ankle International our patient-reported outcomes study on our rostrum repairs with and without augmentation at a median follow-up of 5 years. And while the conclusion indicates similar outcomes between the rostrum repair group and the rostrum repair with augmentation group, there was one significant difference, and if you read the paper, you will notice that the augmented group were advanced through weight bearing and rehabilitation more quickly than the group that was not augmented. Since the talk is titled Evolution of Augmented Ankle Ligament Repairs, I will give you a quick overview of what we've done to get to augmentation of the syndesmotic ligaments and the deltoid ligaments. We started in a similar fashion with a pyramid approach for the syndesmosis, starting with basic anatomy. Our study on the anatomy was published in the American Journal of Sports Medicine in 2015, giving clear landmarks, and progressed to the radiographic anatomy of this in this study, which was published in KSSTA in 2016, followed by this third study to characterize the 3T MRI presentation of the distal tibiofibular syndesmosis and its individual structures in both asymptomatic and injured cohorts. Next, we moved to biomechanical studies like this one, which showed that while sectioning the ligaments in the anterior to posterior direction, cutting the ATFL resulted in the largest percentage reduction in resistance to external rotation, 24%. And there was a similar reduction to external rotation after the AITFL was cut from posterior to anterior. The next biomechanical study looked at surgical techniques ranging from screw fixation, suture button fixation, or a combination of the two. 3 common repairs were compared, and the conclusion was that all repairs provided comparable rotational stability to the syndesmosis. However, no repair technique completely restored rotational stability and tibiofibular anatomic relationships of the pre-injury state. This next biomechanical study looked at a CT analysis of screw versus suture button fixation and showed that a one suture button repair technique and the screw fixation repair technique were comparable for reduction of syndesmosis injuries, although both tend to overcompress the syndesmosis. Based on our prior study on the biomechanical analysis of the individual contributions to syndesmotic stability, given the results showing significant contribution of the AITFL to external rotation stability and the frequency of AITFL injury, where the ligament is difficult to repair confidently, we felt that augmenting the AITFL with an internal brace or suture tape following suture repair would be beneficial. This was supported by this study. The final step is our work on the deltoid ligament in our pyramid fashion and progressing to augmentation as we begin with anatomy. As you see here, for the superficial portions of the deltoid and then the deep portions of the deltoid, the deep anterior tibiotalar and the deep posterior tibiotalar. Next was the radiographic identification of the respective components of the deltoid, followed by our latest biomechanical study, which has been with deltoid testing utilizing the KUKA robot that you see here. 10 cadaver ankles were used. Each specimen underwent biomechanical testing in 8 states. First, intact. Second, anterior deltoid cut. Third, anterior repair. Fourth, tibiocalcaneal augmentation. Fifth, deep anterior tibio-talar augmentation. Sixth, posterior deltoid cut. Seventh, posterior repair. Eighth, complete deltoid cut. Testing consisted of anterior drawer, eversion, external rotation, each performed at neutral and 25 degrees plantar flexion. Anterior deltoid repair restored native external rotation, but not eversion. Tibiocalcaneal augmentation reduced eversion laxity, but tibio-talar augmentation provided no additional benefit. Our conclusion was that a complete deltoid tear caused severe instability of the ankle joint. Augmented anterior repair was sufficient to stabilize the complete tear with no additional benefit provided by posterior repair. For isolated anterior tear, repair with tibiocalcaneal augmentation was the optimal treatment. So deltoid repair with augmentation may reduce or avoid the need for prolonged postoperative immobilization and encourage accelerated rehabilitation, preventing stiffness and promoting earlier return to pre-injury activity. Thank you very much. I hope I haven't bored you with all these research talks that sometimes get a little heavy.